Good evening. Thank you. I'm Claire McCormick, and as chairman of Lancaster General Health's Mission and Community Benefit Committee, it's my pleasure to introduce our next speaker, Dr. Stephen Peskin. Dr. Peskin is the Executive Vice President and Chief Medical Officer for all divisions of Metamedia USA. Metamedia USA is one of the largest medical, communications, and consumer health education companies in the United States. As Executive Vice President, he offers clinical expertise, marketing communication strategy for Metamedia's innovative clinical communications, and conducts educational programs that target healthcare professionals, payers, and purchasers. Dr. Peskin continues to serve on the internal medicine faculty at the University of Medicine and Dentistry of New Jersey. In that capacity, he serves as a clinical preceptor for interns and residents at the Eric B. Chandler Clinic, which is affiliated with the Robert Wood Johnson Medical School. Here to speak about the myths and realities of population health management, please join me in welcoming Dr. Stephen Peskin.
Thank you. I'm really having a lot of fun with this. This is a great little device, and I'd like to thank Mr. Henderson and Dr. Beeman and my good friends, the Searches, for inviting me here, and John Lines. Thank you so much for making this a very easy thing to do. And Betty Beeman and Rose Search, they brought me in and welcomed me graciously and showed me this wonderful facility, and you have so much to be proud of here. I learned a lot in the board meeting, and from Dr. Rybczynski's presentation, the work that you're doing in eHealth, you should certainly be very proud of the work that you're doing in quality and outcomes measurement, gearing up for pay for outcomes and pay for performance, and it's just a great institution. So I'm going to go dark now. So we've got a military man here on the front row. What percentage, and I don't have my audience response, so what percentage of military serviceable women and men in the United States are eligible to serve? Is it 75%? No? No one think? 50%? Yes. Some 25%? That's the right answer. So, very depressing number. And there are two main reasons that individuals that are of age are unfit for service. One, profoundly disappointing, is education. And the second is fitness, and most of that is going to be emblematic of my first slide. So this is a new version of, and whether you believe in evolutionary biology or creationism, I think this slide speaks volumes. So this is how we have evolved. My wife and I were not too many years ago with the kids at Disney World. And, you know, it was just staggering that really a lot of the people look like that dude. So Houston, we have a problem. And overweight is certainly one of those. So some of the major issues, and my talk is on population health management. And really what that means is how we move our population, how this institution, this fine healthcare facility, the physicians and nurses and pharmacists and technicians and support staff who work here, but also the community leaders. You're, Mr. Henderson, in all due respect, you're accountable, and all of us are accountable. So we're accountable, first and foremost, we're accountable for ourselves individually, but the business leaders in this group, the healthcare professionals in this group, the social workers, the individuals who work for nonprofit organizations, we are all in a very real sense, and many of us are parents, and we're very much accountable at that level. So what are some of the challenges? Well, we certainly have poor and uneven access. I saw one of the tables out there this evening was talking about some of the people that are disenfranchised, that don't have access to care. You know, we'll see how this plays out, and our next speaker will give us more insight on the 30-some-odd million who are uninsured or underinsured. We do have escalating cost and volume. I was at a program yesterday in Philadelphia, and one of the presenters presented a slide, and we've all seen this slide before, and I know there's a lot of sort of self-flagellation in the United States, and I don't agree with all of this, but it did show that the cost per individual, cost per citizen in the U.S. that we spend on health care is about how much per person per year? Dr. Beeman? Actually, not quite that much, about half that. It's about $6,700 per person per year. And for that, we get about 77 years of life. Some of that very good life, some of that maybe not so good. The Japanese, homogeneous population, largely one language, largely one culture, much less complicated than the United States. I get all that. Japanese spend $2,200 a year per person for 84 years of life. So, Japanese are the best. In the industrialized world, we're the least cost effective. There's certainly been, the Institute for Health Improvement points this out, the Dartmouth Health Atlas, the link between cost and quality is not there. We have a lot of administrative costs. I used to work for those bad people that call the insurance companies. They're going to certainly get regulated like utilities fairly soon, so we'll maybe see some of that administrative costs decreasing. Dysfunctional payment system. And again, our outcomes are lagging internationally. So the missing link, you remember that first slide showing the evolutionary biology, we need more links. And again, what Lancaster General is doing with My Health, the web portal is great. That's an important part of the link between institutions in the community to the healthcare. Most of healthcare, in all due respect, a lot of good acute care, subacute care is delivered here, physicians in practice, myself included, but most of healthcare happens outside of healthcare institutions. It happens in the community, it happens at home, it happens with lifestyle, it happens with what we choose to do, it happens with the information that we have. So that is really, so again, many treat but few prevent. We really need to create a culture of healthcare. So some of the things that are going on in the current approach, sort of episodic care, restricted information, and I'm glad to see that Lancaster is taking a leadership role in not being restrictive, rather getting to open information, cooperation among providers. Certainly being a primary care doctor, I was pleased to see what you're doing in family medicine here, and that's wonderful. We tend to be seen as the low people on the totem pole: general pediatricians, general internists, family doctors, general gynecologists. That has got to change. We have a perfect storm coming where there's, relative to the population and the needs for primary care, it's not sexy. It's not interesting. I had a show of hands. I was asking the house staff at Robert Wood Johnson in Princeton, about 60 in the group, how many of you are going into primary care? Doctor, how many do you think? Of 60?
20.
Six, yeah. So everybody's going into interventional cardiology and pulmonary and gastroenterology, and so again, we've got a profound disconnect there. So this notion of population health management, it is designed to maintain and improve people's health. Again, rather than waiting for them to need amputations, rather than waiting for them to go on chronic dialysis, which is not honestly is not a very pleasant existence. So this is the notion of population health management. It's looking at the citizenry broadly. It's looking at this construct. Rose and I were talking about the good work she does here at the hospital, and looking at stratification, assessing risk, putting people in a sort of a continuum of low risk, medium risk, high risk. Those that are at low risk you want to maintain their health. Those at intermediate risk, we may need to be looking at things, lifestyle interventions, coaching, behavior modification, dietary interventions, increasing physical activity, dealing with depression, dealing with stress. Goodness knows most of us have a lot of that in our lives. So we look at this construct and we organize and tailor interventions to meet the individual's needs. And at the end of this, we get some positive behavioral outcomes. So again, it is person-centered. It's organized, but it's a population, but it still has to be very personal. It has to be for me, for you, and again, it's not a one-size-fits-all approach. Some of the aspects, again, self-management. It is a fundamental American U.S. value, and one that I adhere to. There is a personal accountability here. It is not someone just taking care of you. And it is focused on behavior and lifestyle. Again, electronic information is vital to this process. I have my iPad handy and use it regularly, but it can also be good old-fashioned printed materials. I picked these up, some diet strategies for enjoyable, delicious eating with fewer calories. So how healthy is your county? Now, Dr. Beeman is a CEO, and like a surgeon, CEOs are often wrong but never in doubt. Just kidding, just kidding. So he said, you all are about 8. And actually, he was spot on, because Lancaster County is 7 in measure of health outcomes, and is 9 in measurement of health factors. So 7 plus 9 divided by 2 is 8. Got it. Okay. So here you are. You're actually not doing too badly. So you look at Philadelphia County, that great city, the cradle of liberty, 67 out of 67. The healthiest county based on outcomes is north of Harrisburg, thank you, Rose, and near Bucknell University, and that is Union County. And the healthiest county ironically enough, near Philadelphia, with regard to these things called health factors, is Chester County. But again, Lancaster at 7 or 9, depending on which aspect of the measure, or rounded to 8, is doing pretty well. And we've got a charge from our CEO. We're going to be in the top 5 before long. So again, this is available at this website if any of you so choose to look at this county by county analysis. Now, this cartoon really shows what I'm talking about here. So what is this population health management stuff? So it's really not that complicated. So there's aspects of screening. That's done in doctor's offices. That's done at the work site. This obviously being one of the largest employers, but it could be at Turkey Hill, at Armstrong, at other employers here. Can be done. Some of this can be done at a referential lab that's easy to get to, accessible. It could be done at a convenient care. I noticed that you all are operating some of those. So this is basically, knowing some of your numbers. Your blood pressure, your hemoglobin A1C, your weight, certainly, things like that. Easy measures to obtain. And then we look at, okay, this is who you are. This is what your issues are. This is what you're doing in terms of some of your behaviors that may be inconsistent with good health. So we target interventions. We target programs. Those can be done with nurses or other trained healthcare professionals. Some of these don't require an RN degree. It can be someone who is just trained in lifestyle coaching. And so a lot of this can be done telephonically. A lot of this can be done using technology, using behavioral psychology, behavioral economics, and then programs that get deeper into working with the physicians, working with the healthcare professionals, working with the nurse practitioners, the physician's assistants, who really extend that into the deeper aspects of healthcare management. So 3 pillars of engagement. A lot of discussion on incentives, micro incentives. We all have our airline programs, and but that's the least important thing on this slide. The most important thing on this slide is at the top, of course, and that's the culture. It's a culture of health. It's the culture of how we engage with people, meeting them where they are, whether it be a Hispanic American or a Mandarin-speaking person, whether it be someone who's health literacy is at a 4th or 6th grade level, or the erudite academics. So really meeting them and understanding, and culturally and inculcating, and then communication. It's how we interact, how we behave, showing some empathy, active listening, and then incentives can be important as well. So again, some of our barriers: fragmentation of the system, malaligned incentives, lack of knowledge on that managing care. That's not managed care a la 1-800-DON'T-DO, but managing care, and then the insufficient use of health information technology. So if we're going to be successful, we really need to strengthen the relationship with our patients, with our employees, with our insureds, however you want to look at him or her. This can be certainly physicians play a cornerstone role here, but also advanced practice clinicians, nurses, pharmacists, other members of the care team, really to optimize care and the service delivery and the active involvement of the individual. Because ultimately, and we docs all see this. Well, you can talk to people till they're blue in the face. They don't listen. They don't take their medicines. They don't lose weight. They let their feet go to whatever. I won't use any expletives. So yeah, I get all that because I've been there and I'm still there. That said, as a system, we can do better. And it is, again, one part self-responsibility, but it is also how we organize, how we coach, how we teach, how we cajole, how we educate, and how we use technology. So a lot of stuff's been tried: disease management, some limited success there; pay for performance, some success, some limited success there. I'm very excited about the first of these. I think the jury is still out on accountable care organizations. I was talking to Rose. There are some patient-centered medical homes that have evolved here in Lancaster. And, I'm not sure about the term, because when it was first used, people said, oh, you're talking about home health care, you're talking about mobile vans that deliver care. We're actually talking about, when we talk about a patient-centered medical home, we're talking about a primary care. It could be an endocrinologist. If the patient has diabetes, it could be a pulmonologist if the patient's primary problem is COPD. But it is a hub. So think about it that way. It is a hub for that individual and the care that they're getting, and again, coordinating that care, taking the time, being remunerated, so the healthcare professionals, physicians, and other healthcare professionals being appropriately compensated for time on the phone, for time on email, for time talking to colleagues about what we're going to do with this individual, and helping them through the system. So again, medical homes, again, typically are primary care practices, but certainly specialists can also be the epicenter of the medical home, depending on certainly if you think about a dialysis patient, the nephrologist is most likely going to really be at the center of the medical home. But again, there are challenges and issues related to the evolution of medical homes, but I do think we have the wherewithal, we have the ability to evolve this model in the United States, and it will lead to, in my opinion, it will lead to better outcomes in a population health notion. Accountable care organizations, there are 466 pages of regulations that just came out about 3 weeks ago, end of October, end of October. I have not read a single page, so I cannot profess to be an expert. But the notion is that you've got a sort of end-to-end solution, hospital, diagnostic imaging, home health, physician practices. You've got that whole end-to-end, and that entity, that sort of extended medical team, is going to be accountable, obviously, as the word implies, for those individuals that are part of that particular ACO. And again, the payments are going to be tied to outcomes and performance and quality measures, as well as the traditional fee-for-service model. So, promise of population health management, again, as Dr. Obczynski said, showed, I think, very compellingly, health information technology is vital to this process. How we engage with our patients, the information that we provide through portals, the information that we provide through mobile devices, whether it be email or text messaging. These are very effective and very powerful tools. One person who's in the tech business said, this is more intimate than jewelry. And sadly, I have to agree. I can't get my wedding ring off anymore. But I might leave home without my watch. Boy, Dad, you're so old school wearing a watch. But I would, never leave home without my smartphone. So again, these are devices that are with many people, not all people. I mean, I understand they're 97-year-old frail elderly who don't have feature phones, let alone smartphones. But a significant part of the population has. Interestingly, I'll tell you a story about my profession and these things. So physicians were fairly slow adopters of computers compared to architects and lawyers and accountants and CEOs and so forth. We have been the fastest adopters of these. By the end of the year, 60% of physicians are estimated to have a tablet, most of them iPads. Why? Because we can walk around with them. We can do this in the exam room and look down and not be annoying and turn away from the patient with the computer screen. They really are very handy, very functional for clinical decision support, for referential, for looking up drug dosing, for going on up to date or whatever. So docs have warmly embraced the tablet. Again, last slide, automation is an important aspect. I do believe that technology will be a strong enabler, but I don't talk about technology-enabled service. I really look at it the other way. It's service-enabled technology. So the technology is not the end-all, be-all. Service is still what undergirds compassion, engagement, good information, meeting the patient where they are, and the technology can be an important conduit for that. So I thank you for your time. I hope this was a good idea starter for you, and I'm happy to entertain any questions if we have any. No. Again, thanks very much. Great to be here.
Thank you very much. That was an excellent presentation, and I hope you're